and thank you everyone for joining us today. I am Amit Saxena along with my colleague Dr. Deepika Chawda from Medical Services. On behalf of Jagsonpal Pharmaceutical Limited Pharma Division would like to extend warm welcome to this 5th episode of SAFOMS web series Quality of Life Issues on MRS on how joint and muscular problem impact quality of life of midlife women, organized by SAFOMS with technical partner smlm.in and Jagsonpal Pharma Ltd, makers of LycoRed and Colla2. Jagsonpal Pharmaceuticals offers you LycoRed soft gel, which found to be very useful to correct nutrition deficiency. It contains lycopenes served to enhance general health and well-being. We also have Colla2 tablet, helps support joint health by reducing pain and inflammations. It contains collagen peptide 2 type, which aids in reduction of inflammation in synovial fluid. For today's webinar, 5th episode SAFOMS webinar series, I welcome convener Dr. Maninder Ahuja. A progressive, thought-provoking leader has created progresses of going digital, online voting, e-newspapers, online journal. She is Vice President of SAFOMS and Founder President of SMLM. Past President IMS, FOGS, Vice President SAFOMS, Executive Member of many societies dealing with health problems like ISAR, IFS, ISPAT, NARCHI. She is the Editor-in-Chief of Journal of Midlife Health and has been felicitated many awards and has many publications and research articles to her credit. We now request Maninder Ahuja Madam to kindly initiate this proceedings. Ma'am, please.
Thank you, Jagsonpal, for being our technical partner and always being a sport. It's an honor to be welcoming all the delegates and also the faculty, which has an international presence because South Asian Federation of Menopause Societies itself is a group of countries, Indian menopause, for menopause societies of the South Asian countries, which have the same phenotype and perhaps the many features of the various physical and mental problems and the dietary things, everything we have the common cultural background sort of a thing. So working together on the menopause front was the natural outcome of our thought-provoking leaders of the past, Dr. Behram Anklesaria, who is no more here. And of course, we founded it in the Sri Lanka. MDP Gunaratne was there. I don't know whether he has joined today or not. Our president, Dr. Rohana Haththotuwa, who is a renowned international leader in SAFOMS, in menstrual disorders, and clinically also so well known. And he has been a great sport all the time, but this time he was in transit. He said, Maninder, I can't join, but I still send my best wishes to all. And he sends a welcome to all the faculty, which are our consultants from India, Dr. Yashodhara Pradeed, Dr. Sanath Akmeemana, and Dr. Rubina Hussain, Dr. Batul Mazhar, Dr. Mary Lumsden. I'm really honored by her presence because I just called her, Mary, can you make it convenient for you to join us here? And she agreed so, I mean, she was busy, but she said, yes, one of these dates I can give you. So I said, this is the topic we are discussing. And she said, okay, I am ready with that and I'll be able to do it. So I think I have introduced Dr. Rohana and all of us know Dr. Rohana. So I'll be introducing, I have introduced Rohana. He's the Secretary General SAFOMS and SAFOMS everything. And Dr. Professor Mary Lumsden, who is the past Senior Vice President of the Royal College of Obstetrician and Gynecologists, with responsibility for strategy unit till December 2019, CEO of FIGO. She's the Honorary Professor of Gynecology and Medical Education at the University of Glasgow, UK, having retired from that university in 2021. CE FIGO from 2019 to 2023, and chair Guideline Development Group Menopause. That is very, very important, what endocrinologists need to know. European Society of Endocrinology for publication May 2024 till, and president of the International Menopause Society from 2016 to 18. So she has been associated with menopausal medicine for a long time. And she is the chair of Guidelines Development Group of Menopause Diagnosis and Management, National Institute of Health and Care Excellence in UK, and president of the British Menopause Society from 2011 to 2013, and ongoing publications with many chapters, including the New England Journal of Medicine and Lancet, and officer of the Order of the British Empire and Honor Award in 2017. So, Dr. Marian Lumsden, it is an honor to have you here, and she will be talking a little bit about our webinar series, and then she will be giving a talk on how to manage osteoporosis in the younger postmenopausal women. Dr. Deepika, can I introduce other guests of honor? Rama Vaidya was supposed to be here, but she's also suffering from URC like me, and she's having fever, so she could not join it. But the main thing is that she was the founder of the Indian Menopause Society, the thought behind that, and she's very much interested in research. She's the MRC of the Kasturba Health Society, honorary director of the Division of Endocrine Metabolic Disorders, consulting reproductive endocrinologist, Vasudha Clinic, New Madhuvan, and research director of reproductive medicine, BSCS Hospital, Andheri, 2007 to present. And she was the chief editor and the brain behind our Journal of Midlife Health of the Indian Menopause Society from 2008 to 2012, and chief editor of Indian Practitioner 2012 to 2016. So she has a long list of achievements. The main thing is she's still working with the Indian Menopause Society. Rama Vaidya, we are missing you here, and we would like to have you again here in the SAFOMS session in the next future. Our next guest of honor is Dr. Yashodhara Pradeed, a very, very active lady who is at this time the vice president of FOGSI, and from 2022 to 2023. So that means moving around the country at a very fast pace. And she was the professor and head of obstetric gynae, Dr. RMLMS Lucknow, senior professor of KGMU, professor ELMCH, and chief editor. She's along with me, the chief editor of this time, Journal of Midlife Health also. And she has been the president of Lucknow Obstetric Gynae Society and many other societies she has been associated with and is working actively. Yashodhara Pradeed, it's wonderful to have you. We welcome you here as the guest of honor. Our next guest of honor is
kind words,
and the expert also is Dr. Sanath Akmeemana, from consultant obstetrician and gynecologist from Colombo South Teaching Hospital, President Menopause Society of Sri Lanka, and Chairman Continuing Professional Development Sri Lanka College of Obstetrician and Gynecologist. So with these words, I think we'll introduce our first speaker, because in this series we are having one young generation speaker, junior consultants, or the consultants at the not very high level, mid-level, so that we can disseminate the knowledge about menopause to incoming generations who are going the flag from the senior obstetrician and gynecologist and menopause specialist. And Avir Sarkar is one of them. He is, of course, from Faridabad. He's MD, DNB, FMS, MNAMS, MIMSA, but he was from the PGIM at Chandigarh, and MBBS from BHU, worked as senior resident at AIM, and at this time he is with the ESIS Medical College in Faridabad. So he has been, at this young age, he has got many awards: gold medal in MBBS MD, first prize in paper presentation in obstetric gynae societies also, in North Zone AICC RCOG also, MTP Con also, North Zone Yuva FOGSI. So a number of papers he is publishing, and he is peer reviewer of the Journal of Midlife Health also. He will be talking on today's main topic of menopause rating scale on the muscular and joint problems. But before that, I will ask Dr. Mary Lumsden to say a few words before her talk. Dr. Mary?
Yes, I'm sorry. I was just trying to get on mute.
Yeah.
Just to say that it's wonderful to be here, to see everybody and see you're still so very active in spreading out news and knowledge of the menopause in India and South Asia in general. And my first SAFOMS meeting was a long time ago when I met Dr. Angelsaria, who I liked enormously and had a very enjoyable time meeting. And I think it is a tremendously good organization. And I've been to several meetings around South Asia over the last 15 years, something like that. It's a
Yeah,
long
2010.
yeah.
30.
And so it is good, and I'm very happy to be here to talk to you whenever Maninder tells me to do so on osteoporosis.
Thank you, Dr. Mary Lumsden. I'll ask our expert chairpersons, but we'll have first the two talks. One will be Dr. Avir Sarkar, then by Dr. Mary Lumsden, followed up that by the panel on osteoporosis. And for that, we have our experts from Sri Lanka, Piyusha Attaputtu. We have from Nepal, Dr. Lakshman. We have from India, Dr. Jignesh Shah. And we have from Pakistan, Dr. Saddakat. I think I have covered everybody. And then will be Dr. Zinnat Nasreen, who will be summarizing whole of the panel later on. And welcome to all our guests who have joined here, who are our executives of the South Asian Federation of Menopause Societies also. I'll be introducing our panelists later on. So please, let's start with the first talk.
Hello, good evening, everybody. So I'm Dr. Avir Sarkar. Today I'll be talking on musculoskeletal pain in midlife. At the very onset, I would like to thank Dr. Maninder Ahuja ma'am and all the esteemed faculties for giving me this opportunity to talk today on this very rarely spoken topic. This is itself musculoskeletal pain in midlife and postmenopausal women is a very less spoken topic, but it is indeed very important topic. So coming to this problem, it is not about weight, but it is about fitness. Fat is not efficient, whereas muscle is. And we should all know that excuses don't burn calories. So it is high time that we talk about this symptom. This musculoskeletal pain syndrome encompasses various types of musculoskeletal disorders affecting bones, ligaments, tendons, joints, muscles, soft tissues, and nerves. The extensive pain and aches and discomfort in various parts of the body, right from the top, from the head to the toe, makes it a very vulnerable problem. It can be both acute and chronic, both focal as well as diffuse. When we look up the literature, the Korean Journal of Medical Science says that the most common problem which stands the highest among the incidents is low backache, followed by other chronic pain syndromes. The huge burden on the population is evident from the fact that it is the second most common cause of disability worldwide. The most common being mental health disorder causing disability. A huge number of 1.71 billion people suffer from musculoskeletal pain, and it takes a toll of 568 millions from low backache. So it majorly contributes to YLD and YLL, that is the years lived with disability and years of life lost. So it is important to talk of this aspect. If we look into the globe of the world, we find that this disorder is most prevalent in the Central American countries, followed by other European countries. India and South Asian countries are still having less of musculoskeletal pain disorders, which ranges from around 1,800 to 2,000 per 1 lakh women. If we do a comparison based on age and gender, we find that women are more affected than males. And moreover, the peak age is between 50 to 55 years. That is just postmenopausal, early postmenopausal period is mostly associated with musculoskeletal pain disorders. A study from China, which estimated from 1990 to current 2020 and even beyond, it showed that women are being more affected than males. Moreover, as the years went by from 1990 to 2020, we found that the disability adjusted life index, that is life years, lived with disability, increases as the years went by. Now, what is the etiology of this varying problem? The major etiology can be related to our workplace, our physical work, our biomechanical symptoms, the increasing tasks nowadays, the load of work, more duration of work, and people sitting in the office desk for a longer time, psychological stress. These are some of the factors which are leading to musculoskeletal pain disorders. Moreover, diet, smoking, sedentary lifestyle, and depression is adding more to this problem. If we look into the pathophysiology, we find that various musculoskeletal disorders increase inflammation and tissue damage as the years go by, thereby leading to release of lipids, cytokines, and growth factors, neurotransmitters, thereby increasing nociceptive stimulation and neuroactive substances which are released. They lead to musculoskeletal pain syndromes. These all lead to osteoclast formation and thereby leading to inflammatory cytokines being released into the dorsal root ganglion, thereby leading to more susceptibility to pain. Now, why to talk about South Asian women in our context? So, talking in this SAFOMS webinar, I would like to add to the fact that the South Asian women have genetically, environmentally, and nutritionally more prone to suffer from this musculoskeletal pain syndrome. This is because they have relatively earlier age of menopause, thereby leading to deficiency of estradiol compared to the Western population. They have low dietary intake of calcium and vitamin D3, less exposure to sunlight in certain sections of the society who are in Parda system or Burkha system, and they have crave for tea and coffee, which is now almost universal. But the high quantity of phytates in South Asian diets make them more vulnerable. The environmental pollution and higher 25-hydroxy D24 hydroxylase enzyme in our Asian women make them more vulnerable. But to talk about the increasing obesity and sedentary lifestyle is something we have to modify at this moment. It is to be noted that calcium and vitamin D3 deficiency has also been found in a huge population. That is, the largest study till date from Frontiers of Endocrinology says that from 1963 to 2005, they have seen that 52% of the women, more than 50% of women from India have been found to be suffering from nutritional bone disease. And 1 in every 2 postmenopausal women are osteopenic. Now, how calcium and vitamin D3 are main causes of musculoskeletal pain problem? This is because more amount of osteoporosis and fractures, and low vitamin D3 also results in osteomalacia, proximal muscle weakness, and it also enhances sensitivity to pain due to stimulation of the nerve cells. So D3 level less than 20 nanograms per ml is associated with musculoskeletal pain syndrome. Vitamin D3, as we all know, is a neuroactive steroid. It modulates neurotransmitter activity and controls various signal transduction systems and proteins involved in the function of neurons. In a study in Current Opinion of Clinical Nutritional Metabolic Care in 2007, they have found that they supplemented women who were deficient with calcium and vitamin D3 for 3 months, and they have found that compared to the pre-intervention phase, the post-intervention period showed a significant decrease in musculoskeletal pain problems when they were supplemented with calcium and vitamin D3. Talking about India, which is the capital of diabetes, it has been shown in meta-analysis that diabetes is also associated with musculoskeletal pain syndromes, mostly the low backache, neck pain, and spinal pain. The exact etiopathogenesis beyond this is not known exactly, but the association has been proved in various meta-analysis statistically. When we talk about our midlife and menopausal women, there has been a recent meta-analysis in a journal in 2020, which has found that it is one of the most severe complaints which women of the postmenopausal period complain of. The prevalence is very high. It is around 50 to 89%, but it is to note that only 25% of these patients come up with a proper diagnosis. The rest 75%, the diagnosis remains unclear, and so patients go from one doctor to another and they are not satisfied of the relief because of the relief of symptoms. The major cause of work and disability related leaves in these women, and it is a contributory factor to years of life lost to disability and years of life lost. So this is very important. So like to reduce our disability adjusted life years, we have to know this problem and treat this problem properly. In a meta-analysis in 2020, it has been shown that musculoskeletal pain disorders are significantly present in most of the, till now there are 14 reported cross-sectional studies, of which most of the studies are showing that it is very much prevalent in the populations. There has been also comparison between premenopausal, perimenopausal, and postmenopausal age groups. The first forest plot in the left shows the comparison between pre and perimenopausal age group. We can find that there is significantly increased musculoskeletal pain disorders compared to premenopausal age in the perimenopausal age group. But the right-hand side forest plot shows that the comparison between peri and postmenopausal age, there is no significant increase in musculoskeletal pain disorders, as the mean of the forest plot is around the null line. So it has been proved in meta-analysis that compared to the reproductive age group, peri and postmenopausal women have increased rate of musculoskeletal pain syndrome, but there is no significant difference between peri and postmenopausal age group. So in the midlife women as a whole can be considered as high risk of musculoskeletal pain disorders. There has also been comparison of moderate and severe degrees of MSP. It has been found that compared to premenopause, postmenopausal women have higher degree of moderate and severe MSP compared to the reproductive age group. Now let us talk about joint pain. Joint pain or osteoarthritis is another entity which has both modifiable and non-modifiable risk factors. Modifiable risk factors can be the sedentary lifestyle, occupation, or wrong habits of sitting or sleeping in wrong posture and joint and alignment, which can be corrected. Primary osteoarthritis can be because of either genetically induced or age-induced or estrogen deficiency related, which is but obvious. We all know that increasing age can lead to decreased matrix synthesis of the bones, thereby leading to reduced IGF-1 and increased cytokines and matrix metalloproteinases, thereby the periarticular muscle strength gets decreased. And the psychosocial factors, if we add to it, leads to more pain and decreased joint function. So what are the factors determining bone strength? The factors can be collagen structure, crystal size and structure, the bone formation, peak bone mass. Peak bone mass, as we all know, that women have less peak bone mass than males, so they are more prone. We all know that the non-modifiable risk factors cannot be changed, like age, gender, or history of osteoporosis. But what we have to focus more is the calcium and vitamin deficiency, sedentary lifestyle, obesity, and lack of yoga, weight-bearing exercises, and stress. This is what we can modify at our age. Coming to a little bit about sarcopenia, I will not talk much because other speakers will talk about it. Sarcopenia nowadays is also becoming a major health problem. This is because it is, leading to various comorbidities like functional decline in physical ability and increasing risk of fall, thereby leading to more amount of osteoporosis, fractures, mortality, and leading to more of the life which is lost to disability. So sarcopenic obesity, because of unhealthy lifestyle and aging and lack of physical activity, is becoming a public health problem, at least in our country. So what we need to aim is a primary prevention. What do you mean by primary prevention? That you have to take the preventive measures from the early age itself, from the reproductive age, from the adolescent life itself. We cannot, always target the old age population. Start targeting the adolescents. When adolescents come to you, when people come in pregnancy or in the postpartum period, then only you try to inculcate these ideas into their mind so that they can start working and they can improve their diet so that they improve their midlife health. So right from childhood and adolescent, we can aim at fitness in midlife. And what we are now aiming is the concept of rectangularization of the survival curve, which I'm very indebted to Maninder Ahuja ma'am. She is always stressing upon this, pyramid. This pyramid is the pyramid which we should all follow. It says that daily exercise and weight control and vegetables and fruits, they come at the bottom of the pyramid. So what is more important for us is daily exercises, weight bearing exercises to reduce sarcopenia, walking, swimming, and every type of exercises should be inculcated into our daily living so that we have a better midlife later on. So be it morning exercises, be it yoga, be it weight bearing exercises, be it dancing, be it swimming, cycling, all types of exercises are very important and necessary. So regularizing the survival curve, this I want to stress upon. This is because what we want now is with various types of drugs, we have increased our survival age. But with increasing survival age, we have to also rectangularize the curve so that we can decrease our life, the years lost to disability. If we have more of years to morbidity and disability, then it is worth not living. So at the end, I would like to say that have a healthy living, eat properly, diet, proper lifestyle, be fit, and have a healthy life. So the carry home message of today's talk is menopause is a natural phenomena. Don't worry, many sail through properly, but the window of opportunity, we have to take care and we have to modify our lifestyle. The primary prevention is of utmost importance with early screening, early detection, and we have to focus on prevention rather than the treatment aspect. So better late than never. Start today itself. We have to aim high, and healthy lifestyle from childhood will help in shaping a good midlife health. So thank you so much.
Thank you so much, Dr. Avir. You have really, as an opening batsman, you have delivered the excellent talk on musculoskeletal pain. That's the most common.
Yes, ma'am.
Complain when you sit in the OPD, every third woman is complaining of the backache. And when you examine, do the test, because you do only the basic test and you do not find anything. So you are not able to exactly accept that counseling, which is very necessary for them for the preventive measures. Osteoarthritis is a most prevalent situation because of the factors you have already enumerated. But I disagree with the statement that out of 568 million suffers from the backache, but the South Indian and Indian population suffers less from the backache in comparison to the whites. When we know that because it is not only that they suffer less, it is we are not having the data. We do
Yes.
not continuously upload our data, because if you see every third person, the Western, they have all preventive measures. They have got a better diet. Their calcium supplementation is much better than what we have. There is a vitamin D, of course, they are having the white skin, so it is the absorption is less in comparison to the people who have got a black skin. But still, because of their diet, they do not have the sedentary lifestyle. I have learned from them that what the Indian culture is, that as the women get older, the younger family members say, you don't have to do anything, you just sit. And that's not good. They have to be encouraged. So they should have the quality of life, and it should be it is going to help them to to develop less sarcopenia. So it is very well you have said, because time is less, so I will not go into the detail of it, but you have very well summarized. We are not able to all the time see that the bone growth factors, including the BMPs and the TGF beta, or the insulin-like growth factors, IGF-1 and IGF-2, later derived growth factors, and the fibroblast, acidic and basic fibroblast growth factors. So we are not able to do this. Probably if we can do this, probably we can pinpoint what is the problem. So it is, I would like to say that this prevention is not going to come when the woman is getting old or after 40, because the peak bone mass is achieved by the age of 18 to 20 in the females. So it is the adolescent, we have to educate the parents that if you do not want your children or your both male and female, but female are more because they are having the pregnancy and the lactation. So they use more of their calcium. So if you do not want that your daughters should suffer like you are having the backache, and you go everywhere, probably
We had that topic
we are not having any other thing. We just give them an analgesic most of the time and calcium and vitamin D, which they do not take because we do not use the proper calcium compound, and we do not emphasize that calcium carbonate has to be taken after the meals.
Thank you, Dr. Yashodhara.
1200 milligram of the calcium and 600 to 800 international units of we should choose a product. We should not go away with the pharmaceutical companies, what they are saying. We should choose which is having this much of a strength. And then probably we will maybe able to do this better lifestyle, quality of life, which is very important, which we all our menopausal women are lacking. Thank you so much for delivering such an important subject with such brilliance.
Thank you, Yashodhara. But we have our another specialist also from Sri Lanka, Dr. Sanath, Akmeemana.
Yes, Dr.
Sorry,
Sanath.
sir, I was not able to see your slides, so did not introduce you. But he was the president of Sri Lankan Menopause Society.
In fact, I am the past president of Sri Lanka Menopause
Past president of Sri
Welcome,
Lankan.
Dr. Sanath.
He gave a very
Welcome,
good
Dr. Sanath.
comprehensive
We are waiting for
lecture.
your comments.
Yeah, welcome,
I
Dr.
think he
Sanath.
gave, I think the previous panelists also gave a very good description. I think the speaker gave a very good description, and I think excellent presentation for a young person. And I agree that the prevention should start from early life and health education, parents and the children, very important in encountering this problem. Nothing much to say. A very good presentation. Thank you.
Thank you. Thank you, Dr.
Thank
Sanath.
you. And other thing I want to give Dr. Maninder. Yeah, thank you very much for organizing this event.
Thank you.
And on behalf of SAFOMS. It's excellent work. I know how difficult it is. Thank you, Dr. Maninder.
Thank you. Thank you. Dr.
Thank you, Dr. Maninder, for making a part of me into this SAFMOS quality of life webinar. Thank you so much. And my pleasure to meet so many galaxy of the stars.
Thank you. Thank you. Because we will be running short of time. So we have another speaker says, but Dr. Avir Sarkar, I have to mention one thing. You have very beautifully explained everything, that it starts in the menopause transition. So that is the period when we are finding many inflammatory markers now. So many of these conditions are now interrelated. We will be discussing later on also. But one thing which I want to share with all of you is, recently I realized when I was looking at the infertility patients, and the patients around the age of 40, 45 or 50, when they were coming for the infertility with the already deficient estrogens in them, and sometimes we had to take the ovum donations, or we have to try other measures to if we can get a few eggs or not. Then the main complaint they gave to me was, "Docs are both okay, that will go on. But I am having so much aches and pains. Please do something about it, because when I get up early in the morning, it's not possible for me to get up even." So that made me realize, yes, we are missing out these symptoms. Women are there, they are complaining. We are not even documenting these symptoms, that they are because of the hypoestrogenic state. So this part of the women's life has now become one of the most important. It's more important than reproductive also, more important than adolescent also. So welcome to all these menopausal specialists here who have to take this torch forward. And without wasting much time now, I think, Dr. Mary, would you like to give any comments, or you like to proceed with your talk?
No, I thought it was a very comprehensive presentation. Thank you very much, Dr. Sarkar. And I will be able to cut a little bit out of my own as a result and keep it shortened to time. So no, thank you. It's most enjoyable.
Thank you.
Thank you.
Yeah, congratulations, Avir. And now we, please, Dr. Mary, you share your presentation now. And we'll have the same chairperson, Dr. Yashodhara and Dr. Sanath here. Bone health in younger postmenopausal women is another very, very important topic, which she will be explaining how to go about it, but it's a little different than when the established osteoporosis is there. Yeah.
All right. Well, sorry, I'm just trying to get it. I seem to have a large gallery view of people, which I mean, I can't. Got it. That's brilliant. So what I'm going to be doing now is talk about bone health in younger postmenopausal women. But I'd like to start by saying thank you very much for the invitation, and also for such an excellent start to this webinar. So what I'm going to do is to talk about osteoporosis specifically. What is it? How is it detected? How can it be treated? And how can it be prevented? So inevitably, there will be a little overlap with what we've just heard. Now, why is it important? Well, the reason is that the incidence of osteoporosis is going up, and actually it's going up worldwide, not just in South Asia or Europe, but generally. But in this image, you can see you've got females, you've got males, and we've got South Asia, and it is a big problem in South Asia. And I'm glad that there is recognition of this, because I haven't always felt that that's the case over the years that I've been among you. Now, we can see from this image that hip fractures, in particular, are very common actually in all women. In Black women and Asian, they're somewhat less than in white women, but they are still common across the board. Why is it really important, or gets more important? Well, of course, our lifespan is increasing. Here you will see India, bang in the middle here. I think India is getting on for over 75 years. Japan, much more. And then parts of sub-Saharan Africa are still lagging behind for lots and lots of reasons that I'm sure you'll be aware of. But what I want to spend a bit of time talking about is why there is decreased bone mass and bone quality, leading to fracture, often with the most minimal trauma. I'm not going to talk a lot about genetics, in fact, or age really, because there's not a lot we can do about it. Diet we can affect, as we've been hearing about calcium and vitamin D. Menopausal bone loss we can affect to a degree. And then there are many other factors of importance. This image illustrates 2 or 3 things. One is that vertebral fractures are the commonest. Secondly, that hip is the second most common, whereas wrist just tends to even out, although it's one of the early fractures with which women often present. But vertebral fractures, I'm going to dwell on a little more in a few minutes, because they are of significance and are often completely overlooked. So we'll have a bit of physiology to start with and talk a bit about bone dynamics. There is resorption of bone lasting about a month, formation lasting around 3 months, and these in pre-menopausal women and in men tend to be coupled together. Now, when you get to an osteoporotic situation, you get uncoupling, and the osteoclasts get the major share of what is going on in bone. They resorb a greater amount of bone, leaving a deeper resorption cavity. The osteoblasts, which build up bone, then lay down a smaller amount of bone than was resorbed. And so you can see that things will gradually get thinner and weaker. But it is quite complex, and I just show this image to show that there are many parts of this system that can be affected by pharmaceutical agents and other agents to impact on bone density and osteoporosis. And the 2, I think, of major importance tend to be estrogens and the rank ligands, which are widely used for established osteoporosis, the latter in particular. Now, I've got 1 or 2 images that I think really say it all. You've got a large cavity in bone, an osteoclast, which is on the left here, and that is about to start chewing away again. So you really do get a lot of cavities in the bone. And so you change from this strong bone, this nice vertebra here, to this. And my goodness, what a difference. Very thin bridges between the different parts of the bone and these large holes with no strength. And so the bone tends to collapse and fracture very easily. And so what we really need to remember is that osteoporosis is a skeletal disorder characterized by compromised bone strength, and it predisposes to an increased risk of fracture in a big way. Now, this, I think, is a very important slide. Here, you've got a wedge fracture. And certainly in white women, you'll see many, many, many older women who've got what we call a dowager's hump, where there is curvature of the spine. And these narrowed intervertebral spaces and disc mean that there will be impingement on nerves. And this can be excruciatingly painful and very difficult to treat. And so part of our prevention must look at vertebral fractures. And if you remember, they are particularly common. Now, a second very important slide is this one, which shows age, increasing bone mass, and the risk of fracture. When you are 80, 75, 70, dare I say it, you are at increased risk of fracture regardless of your bone mass, unfortunately. Whereas when you're 55, 59 even, and younger, you don't. So that is the time for prevention. That is the time when we need to be focusing on preventing as far as possible, fractures in later life. Because when we look at fractures, what we forget is the increased mortality, and it is really quite significant. And 20% of women will be dead within 2 years of a fracture, and 80% have decreased mobility. Now, this is another very important slide, and we've already alluded to it. Attainment of peak bone mass by the age of 30. So this is where we focus on building bone mass. We consolidate it between 30 and 40. And then we have age-related bone changes in both genders, but with increased bone loss around the climacteric in women. And here we have osteoporosis. Now, there's been some very interesting studies, and one of these is the SWAN study, undertaken in the United States, but of a number of different ethnicities. And they find that things are a little more complicated than you might realize. But important fact number 3, bone loss starts before the final menstrual period. It starts in the menopause transition. So this is really important to remember. And I think that some people they're not aware of that. There is confounding by body size, and they use here an example of Japanese and Chinese women who have lower bone density than white women, but have lower fracture rates because their bones are stronger for some reason than white women. And so this is something that we need to follow up on. This is a very recent publication. Now let's think a little bit about trying to identify those at risk of fracture. And there is a FRAX tool which has relevance to vast numbers of countries all around the world, including in Asia. And what it does is look at a number of risk factors, and then it includes bone densitometry as well to try and determine what fracture risk and the necessary preventative strategies. This actually is for China that I put in as well. I couldn't manage to get a picture of India, I'm afraid, or any of the South Asian countries. But it works very, very well for many different nationalities. And so what do you get? You will get something like this, where you'll plot the 10-year probability against age, no treatment. You can, if you don't have routine measurement of bone mineral density, include that at this point, and then you can make a final assessment with the BMD. And this is shown here, where you've got no risk factors to start with. Then you've got a prior fracture, which is just something in history or a strong family history of osteoporosis. And then you've got your bone mineral density measurements that can be brought in to just give a rather more clear estimate of what your fracture risk is. And then you can work out a management algorithm. And so you'd have low, intermediate, and high. And in high, you really do need to think about treatment. In intermediate and low, you can be thinking about the preventative strategies. What about treatment? And I know that you have a lot of discussion in your own literature about osteoporosis and potential treatments, but these treatments really are common the world over. This, in fact, is from a European publication, but it is still relevant to you. And I want to just mention particularly HRT, which is a very useful preventative and treatment. The bisphosphonates widely used throughout the world, in that particularly the oral bisphosphonates actually not terribly expensive. And these, of course, that is, of course, of pivotal importance. But let's think a bit about lifestyle first. We've had some discussion of this already. Genes, apart from just mentioning the impact of ethnicity, I think we'll leave to one side. We've got diet, exercise, social activity, and productive pursuits, i.e. not sitting around all the time and drinking coffee. So I think vitamin D, it always amuses me because in Scotland, where I live, we don't have a great deal of sun. So vitamin D deficiency is prevalent throughout the population, not just in women or anything else. It's just we're all vitamin D deficient because we don't get enough sun. And then this is the metabolic pathway you did hear a little bit about in the first presentation, and some of the dietary sources that you can get. Now, I put these down because it's not just the dairy products, which have a lot of calcium and vitamin D in, but also the various fish oils. And so you can get quite a lot in your diet. And the other thing is that both calcium and vitamin D are incredibly cheap. And so there is no reason actually for not supplementing diets on a fairly wide scale. And we heard that you take calcium carbonate after food. And part of the reason for that is the irritation to the gut that can occur. But it works. And this is a dose response curve, which is very clear here, as the increasing doses of vitamin D will increase lumbar spine bone mineral density. So it is definitely worth doing. And vitamin D, unless you take it in vast quantities, is actually not going to do you any harm and is likely to do you quite a lot of good. Exercise, I won't talk about a great deal because we've had this mentioned already, but I'm going to just emphasize how important it is in general sense of bone and muscle strength. And what we need to think about are what supports bones, what supports joints, and here we have muscles. So what you want to do is tailored exercise that will impact on falls in the elderly. You want to stop them falling about, and they'll only not fall about if they've got strong muscles and also they have quite good balance. But that is the discussion of another presentation. Now, I put these in so that I can just talk to a few of the points in it. Starting on the right-hand image, exercise in childhood. They need to not watch telly, not watch their wee iPads or iPhones, as many do in the West, but get up and run around like my grandchildren do and have been doing extensively for the last few days. So we're all getting exercise. But 80% of children in the UK probably do not get enough exercise, which is a formidable number. And the emphasis on the fact that fragility fractures are so common. And again, people don't realize it. The only reason I include this is it was an image I got off the internet, as you can see. And it gives you 3 messages. You want strong muscles and bones. You need to be steady and you need to stand up straight. And I know personally actually how difficult it is, but how important it is. And as being of an age where musculoskeletal aches and pains are the bane of your life, then I think that it is something we should all be stressing to anyone that we meet. And this is just your own risk assessment chart for deciding whether you use drugs, you use preventive strategies, and you ask Maninder for her advice on exercise. And I do remember all the dancing I've done in India over the years and how good this is. I'm going to mention a little bit about estrogen to emphasize 1 or 2 important points. You all know that HRT is effective in treating osteoporosis and in preventing it. However, you can see in this image that when you stop HRT, unfortunately, the benefit tends to decrease quite rapidly. This is a control just for comparison. And there'll be huge numbers of studies which show that while people are taking the HRT, it's incredibly effective. And possibly for a little while afterwards, all fractures benefit from HRT. If women take it because of symptoms or just because they do, then they will get some skeletal benefit. And again, it benefits muscle strength. And so that is another thing that is worth bearing in mind. But there are one or two issues here. And I think this, which is the Women's Health Initiative long-term follow-up, really says it very clearly. These are women 50 to 59, heart disease and breast cancer. Really minimal risk, and it's not significant. 60 to 69, you begin to get a little bit more in the way of significant side effects. And 70 to 79, you're getting a lot of side effects. And when you think about when you are going to have the biggest chance of an osteoporotic fracture, then you realize that you will be taking it at 70 to 79. And so you need to think through the benefits and the risks extremely carefully before deciding on what you're going to do. And I think for many, this isn't a good option for osteoporosis on the long term. So I think in conclusion, all women should understand lifestyle factors that influence bone density above everything else. Screening with bone densitometry can help identify those at risk where it's possible, and appropriate preventative measures should be introduced, particularly those related to diet and exercise. And hormone therapies in women are beneficial, but they must be aware of the risks and benefits of the treatment. So thank you very much for your attention and listening to this presentation.
Thank you, Dr. Mary Lumsden. It was a wonderful talk. Before our chairperson's comment, I just wanted to clarify one thing, because whenever I talk that in the menopause, perimenopause, early transitional menopause, if we have high risk of osteoporotic women developing osteoporosis or they are osteopenic, should we be starting HRT with the proper counseling or not? Because I feel if we start them early, that will be much more helpful than rather starting late.
Oh, definitely. I think if you're going to start HRT, I would start it perimenopausally, definitely. The risks are so much less, and you do get this beneficial impact on bone. And although osteoporotic fractures are more likely in those who don't take HRT than those who do, even at a young age, women are stronger, their muscles are stronger, and their balance is better when they're 45 to 50 than when they're 70 to 75. Balance begins to go. And I think anybody on this call who is over 65 to 70 will know that the balance is just not quite as good, and the muscle strength goes. So I think that is what many women now in the West really concentrate on, is trying to keep their muscles strong. And I think we need to be learning from you all, actually, as to how we do it. But I do use a lot of HRT, yes, but I am very careful to counsel women so they know what they're taking, basically, so they make their own informed decision as far as possible.
Yeah, can we see any questions here? Treatment should start in utero. That is the latest which is coming up now about the prevention of osteoporosis and all these musculoskeletal problems, because We have problems starting. We have now proof of in utero origin of many diseases and osteoporosis. If the women are not given proper calcium and vitamin during their pregnancy and the placental transfer is not there. They have seen in rats that even if they later on add the substitute by the calcium and vitamin D later on, but if they were deficient in the pregnancy period, they are not able to attain that bone mass density. So that is what has been seen.
Yes, in a way it is very complicated because you know, a lot of it is related also to in utero and early hormones. If you think of the difference between males and females, you know, they have more dense bones, and that's, you know, the end to it. And it is complex, as you say, Maninder, but we do need to be raising awareness of it.
Yeah, awareness is very, and Dr. Mary, I'm very happy now to see that many more studies are coming up into the menopausal age group. And that is what we feel very happy, because that is what we need. We need research, we need new thought processes, and we need new ideas to come into the menopausal medicine, because it's a very recent science.
Yeah.
So as compared to the reproductive science, it's a very recent science. But still, I think we have done very well. Dr. Yashodhara and Dr. Sanath. Dr. Sanath, would you like to give any comments?
I think she gave a very balanced talk about osteoporosis and the prevention. I'm very grateful, and I want to thank Professor Marianne Lumsden. She's a long-standing friend of Sri Lanka also, and she's really ready to share her knowledge with us all the time when we invite her. Thank you, Professor Marianne. Thank you very much for that talk.
Thank you, Dr. Mary, for your comprehensive talk, evidence-based comprehensive talk, I'll say, on the bone health in younger postmenopausal women. It's a very, very important thing which you have talked about, and we have discussed about the HRT also, because we know that Indian women is having menopause at lesser age in comparison to the Western world. So because our average age is 46.6 years, while the Western age is 51 years on an average. So previously, we never had this idea. It's a very good thing because of this menopause that we started at least having the research, and we started having the thought process. We are getting many articles. We should not compare. We should compare 46.6 not with the 51 years. One thing. Then, as you have already emphasized very well, that the osteoporotic fractures are much more common if you compare it with the combined heart problems, breast problems, and the stroke combined. So we should talk every time about the bone health. That is what I feel, that in each OPD we should make, because you know India, so there's nothing to say. You know India, that there are so many patients are there, and we do not have that much of the educated paramedical, which I have seen in the Europe and in the USA. Because these paramedicals can do all this counseling, which here a doctor is going to do. So we have to make a specialist post-menopausal health paramedical workers. That's very, very important, because I have seen there we have got a separate people for the family planning. We have got a separate people to talk about the reproductive pregnancy and other things. Yeah, so we should also have this thing. Yes. So again, I will emphasize, which I have already said, education in schools. We are doing the education for the menstrual hygiene, other things, but this is also very important. Education, the nutrition in the youngs, to prevent it releases the bone loss into the, or at a decreased level, decline of the bone mass into the, when they enter into the adult. And plus you have seen very well that pharmaceutical compounds and the HRT, that if you start earlier, it can slow down the osteoporosis. So thank you so much, but effect lasts only till you take. So these are the very important things which we have to emphasize while doing a counseling for HRT, and also making them to continue, because here the people are very much sensitive about the medicines as a whole. They are very sensitive. So they need a lot of counseling. Lot of counseling is only going to improve the bone health in the younger people.
Thank you, Dr. Yashodhara. I think now we proceed with the panel. Thank you. Thank you very much. And we proceed with the panel. Our first talk will be by Professor Piyusha Milani Atapattu. She's from Sri Lanka. And she is the professor in physiology and specialist physician, Faculty of Medicine, University of Colombo, Sri Lanka. And she is the president, Physiological Society of Sri Lanka. And she is the president-elect, Menopause Society of Sri Lanka. Piyusha, welcome, working more with you in the Menopause Societies. And then we have Professor Zinnatara Nasreen from Women's Medical College Hospital from Bangladesh. All of you know her. She's very, very active. She's chairperson of Scientific Committee of OGSB, member secretary CPD Committee of Bangladesh College of Physicians and Surgeons, Secretary General Polycystic Club of Bangladesh. She's so much interested in all the areas of the women's health. Welcome, Professor Zinnatara Nasreen, and she'll be summarizing at the end of the talk. And Dr. Professor Sadaqat Zabin, she will be speaking on the peak bone mass density, I think, which is very, very important issue, which has already been highlighted. She's the Vice President of the Menopause Society of Pakistan. Welcome, ex-secretary and now member of the Faculty of Obstetrics and Gynecological College of Physicians and Surgeons of Pakistan, Master in Health, Principal Investigator of Women Trial, Supervisor, Examiner, Paper Setter, Convener for CPSP since 2004, and presently working as a consultant in Rahim Medical Center, Peshawar, Pakistan. Welcome, Professor Sadaqat Zabin. And then we have Dr. Lakshman Rijal. It's wonderful to have you, sir, here from Nepal. And he's the Adult Trauma and Hand Surgery Fellow, 2014, from Singapore, and TTSHN Psychot Trauma and Hand Fellowship Award 2013. Hong Kong, he got another fellowship awarded, fellowship from 2013, and the DPO Asian Travel Award. Reviewer of International Journal of Shoulder Surgery. Welcome, Dr. Lakshman Rijal. He'll be talking on the medical management of the osteoporosis. And then we have Professor Brigadier General Suraya Rahman, who is very well known. She's the Vice President of SAFOMS and ex-head of the Department of Obstetrics and Gynecology, and CMH Dhaka Advisor Specialist to DGMS, Ministry of Defense, Bangladesh, Vice President of SAFOMS and Vice President Bangladesh Menopause Society. Welcome, Professor Brigadier General Suraya Rahman, and she'll be talking on the very important subject of triad of sarcopenia, osteoporosis and vasculopathies. And Dr. Jignesh Shah from India, our past president of Indian Menopause Society and senior obstetrician practitioner from Ahmedabad, practicing since 37 years. And recently in Surat, he has given an oration on menopause clinics to set them up. And he'll be talking on alternative therapies, which is very important role of exercise in the osteoporosis. So we'll have a plethora of specialists who will be talking on various topics of the menopausal health. And what we have done, I think should I share now? What webinars we have done so far is on the hot flushes, on the sleep disorders, on sexuality issues, on mood disorders, and depression. And we have covered on cardiopathies also, metabolic syndrome also. And now we are doing today on the musculoskeletal pains. And yeah, these are the webinars which have been there on Tuesday, 10th May 2022, we had done the metabolic syndrome, then hot flushes, how hot they can be, 16th March, then sleep in midlife, quality of life on 13th April. And then in the May, we had done mood disorders, anxiety and irritability. And after May, we are doing, we have done one more, July sexuality. Yes, we had done on 17th July sexuality. And today we are doing this musculoskeletal pains and osteoporosis. And what we are left now is the bladder problems, vaginal problem, and then risk assessment tools in the menopause, because other topics we have all covered now for the year 2023. So next 3 months, we'll be covering these topics. So my first, I think, will be Professor Piyusha Attapattu. She'll be talking on the magnitude of problem in the SAFOMS countries of osteoporosis and pathophysiology and short diagnosis. So Dr. Mary has covered a lot of things, but what we SAFOMS countries are facing, Piyusha will be telling us. Piyusha, to you, Dr. Piyusha. Yeah, nice to have your wonderful smile here, Piyusha.
Okay. Thank you very much for inviting me. Anyway, now the thing is, now I've just got only about 8 slides, and my work has been made very easy by the 2 previous speakers who have actually discussed most aspects of this. So anyway, I'll be just summarizing or touching on it. So it's going to be just a few minutes on osteoporosis burden on South Asian countries, pathophysiology and diagnosis, as this was a topic that was allocated to me. So when you think about the prevalence of osteoporosis in South Asia, I did a lit survey, and then I found that in Sri Lanka, it's been found up to 45% of postmenopausal women, and in India, the prevalence ranges in various studies from 8 to 62%, because that's different communities, depending on whether they're affluent or they've got poor facilities, they've got different prevalences. Bangladesh, the risk of osteoporosis among adults in Dhaka city was 37.3% in one study, but other studies have found that it's around 40% of osteoporosis, as well as 40% of osteopenia. In Pakistan, the prevalence of osteopenia and osteoporosis again varied. That was from about 20 to about 49.3, maybe about 50%, again in different studies. In Nepal, there weren't that many studies available in the research, but it showed again up to about 40% of women are involved, are having osteoporosis. So basically, what we can see that the prevalence of osteoporosis in South Asia is not little, as we think, like when we compare to European countries and the Caucasians, we think we have less, but it is actually not so. And this is quite, this gives us happiness for South Asians, because we can see that the annual incidence of hip fracture, we are in the lowest group, less than 150 per 100,000 population. Again, compared to the Caucasians, this appears to be quite low. However, this key statements by International Osteoporosis Foundation actually shows a true picture, which is not quite so happy, not so rosy. We know that advancing age is a major risk factor for osteoporosis and fractures, and Asia is rapidly aging. And the incidence of hip fractures have actually risen 2 to 3-fold in most Asian countries over the past 30 years. And it is predicted that by 2050, half of all osteoporotic fractures will occur in Asia. Asia actually includes Southeast Asia as well, but still that is a pretty gloomy picture. And now for South Asian countries, which are basically having less facilities, osteoporosis is greatly underdiagnosed and undertreated, especially in rural communities. And many countries are severely under-resourced with less than 1 DEXA machine per million population. And the recommendation for Europe is 1.1 machines per 100,000. So ours is again quite low. In Sri Lanka, actually, we have less than 10. The calcium intake falls far below the FAO and the WHO recommendations. It was discussed earlier. And again, vitamin D deficiency or insufficiency is prevalent in both sexes and in all age groups in South Asia. And to make matters worse, only a minority have a health insurance, making care after a fracture or seeking health care for whatever the problems, it becomes less feasible for many. This is just touching. We know that osteoporosis increases with age in both men and women, and we know that the primary contributor in postmenopausal women is estrogen deficiency, where we see that there's a rapid decline in bone mineral density in both cortical and trabecular bones during the late perimenopause and the first postmenopausal years, which will again continue to decline. Now comes the pathophysiology. We know in the bone, we've got osteoblasts and osteoclasts and of course osteocytes. Now these are the two key players, osteoblast and osteoclast. And we know again that we got the rank ligand and PTH stimulate bone resorption. So therefore, we can see the rank ligand here floating around, and this OPG is osteoprotogerin, which is actually a decoy receptor for rank ligand. So we can again see our macrophage is converted into osteoclast precursors when this rank ligand binds to rank. And then it is converted into an active osteoclast, which can continue to resorb the bone. And for bone formation, we need the osteoblasts, and osteoblasts, therefore, will counteract this. And the bone remodeling, we begin with it's from here, bone resorption comes first, and bone formation occurs next. And this goes in a cycle, strengthening the bones. Now, what is the role of estrogen? Estrogen promotes the formation of both trabecular and cortical bone. Now, let's see the first part, the bone resorption, how estrogen helps. Estrogen decreases osteoclastic activity and promote the apoptosis of osteoclast, and also repress the formation of osteoclastogenic cytokines, which are the various interleukins and the TNF-alpha, etc. And also, estrogen decreases cathepsin K and heart-rate-resistant acid phosphatase, which are released, which are used by the osteoclast to resorb the bone. And also, estrogen increases the OPG decoy receptor, OPG or osteoprotogerin, which is the decoy receptor for rank ligand. Therefore, binding of rank ligand, which will prevent it binding with the progenitor cells. And okay, what about bone formation? Estrogen promotes osteoblastic activity and increases osteoblast differentiation by upregulating the bone morphogenic protein 2, and also prevents osteoblastic apoptosis. So therefore, this shows just the same thing. So basically, these little yellow things are the estrogens. We can see that, we can see that estrogen will promote osteoblastic activity and inhibit osteoclastic activity by inhibiting rank ligand, inhibiting T cell activity, which promotes the activity of rank ligand, and also estrogen will inhibit the monocytes forming the pre-osteoclasts, and it promotes osteoclast apoptosis, and it prevents the osteoclast from releasing cathepsin K and these acids, so that it will prevent erosion of the bone. So therefore, basically, therefore, lack of estrogen will contribute to the pathophysiology of postmenopausal osteoporosis in a major way. So finally, my last slide is the diagnosis again, which has been addressed. So diagnosis of osteoporosis, we all know that the gold standard is DEXA. And DEXA classification measures bone mineral density. And this is the WHO and the IOF adopted classification of normal bone BMD with t-score less than -1 or greater, osteopenia between -1 and -2.5, osteoporosis is -2.5 or less. Severe osteoporosis is osteoporosis with a fragility fracture. However, now there are other guidelines because coming up, because DEXA, again, as we saw earlier, is not freely available in many South Asian regions. So AACE, American Association of Clinical Endocrinologists, in 2020 added that osteoporosis is diagnosed with low trauma spine or hip fracture with or without BMD feature suggestive of osteoporosis. Or if someone has osteopenia on DEXA and with either a high frac score or a fragility fracture, that also supports the diagnosis of osteoporosis. And these are actually more user-friendly for South Asian countries. Thank you. So I have actually just briefed about the magnitude of the problem, then a little bit about pathophysiology, and just one slide on diet.
Dr. Piyusha, in a very short time, you have given a very wide picture of the South Asian countries, what is happening, and what we see that we are having less fractures, less this, it's not so. We are having much more, but the diagnosis is not there. So hardly people who come with the backache, we are able to give them even the X-ray to see. BMD is a out of approach to all these women to see that they are not having a vertebral fracture, they are not having the decreased spine. In fact, we are not able to see their heights, because that's the most common thing. If you see the heights is decreasing, is a very first sign of the osteoporosis. And women will not realize that, because most of the petticoats are increasing. The length of the petticoat which they used to find is shorter. Now they're longer because the height has decreased. This is, and the sarcopenia, that they are not able to open the bottle or something like that. These are the small, very important signs which symptoms you have to explain to these women. If you get this, you have to come and get advice. Yes, Dr. Maninder is there now.
At the end of the panel now, Dr. Zinnat will be taking up all these questions and answers and discussions. So we'll be just going on to the other speaker now. Yes, as Yashodhara was saying, clinical diagnosis is very, very important. So let's go to move to the next speaker. That is from Pakistan, Dr. Sadakat Zabeen, who will be talking on peak bone mass, because importance, first primary prevention is that the women should not enter into menopause with already osteopenic state. So they have to achieve during the adolescence a peak bone mass, which the maximum they can achieve, and how they can achieve that peak bone mass from 16 years to almost 19 years, then there is a plateau and then they start falling. So Professor Dr. Sadakat Zabeen, it's to you now.
Thank you, Dr. Maninder, Ahuja, and the presidents of SAFOM, elect President SAFON, Dr. Saida Batul, and President Pakistan Society, Menopausal Society, Rubina. Today's my talk is the achieving peak bone mass in adolescent to prevent osteoporosis. We know that this osteoporosis is a bone thief. It means that it's a silent disease which is killing the disease without giving any symptom. So it's a progressive systemic skeletal disease characterized by low bone mass, which results in fragility and susceptibility to fracture, typically as a result of hormonal changes or the deficiency of calcium and vitamin D. It has been noted that it is causing nearly 9 million fractures annually worldwide, and even in UK, they are seeing about 300,000 fractures per year in their hospitals. It means it is also common in the Western countries, though it is very common in our area of the world, but this is also common in the Western countries. We must know the bone structure. The bone structure is mostly composed of protein, collagen, and it forms the soft framework. The mineral which is mostly present in the bone is the calcium phosphate, which hardens this framework and giving it strength. The bone content in our body is about 99%, which resides in the bones. The calcium is residing 99% in the bones, and the bones have internal structure similar to honeycomb, making it rigid. Still, it's a lighter in weight. Now, there are numerous factors which affect the osteoporosis, and they are the risk factors for osteoporosis. The gender is the most important one because the females are prone to develop this problem because of the effect on the hormones and also the deficiency of calcium, vitamin D, and usually the inactive lifestyle. The other important key determinant is the peak bone mass. Now, the peak bone mass, we know that the ossification process starts just from the intrauterine life. Here you can see that the bone formation starts in the intrauterine life. As it has been said that the baby in the uterus requires calcium and vitamin D from the mother. So if there's no adequate amount of the calcium and the vitamin D in the diet of the mother, the baby will be born with the weak bones, and also they are prone to develop rickets and other types of bone diseases. So the process starts in the intrauterine life, which is the 3rd month of the life, and it is completed by late adolescence. In this slide, we can see that the bone starts forming, but it's very slow in the childhood. As the person reaches the puberty, there are spots of growth and the effect of the hormone, which results into increased bone mass, resulting in the size and shape, increase in the size and the shape of the bone. It is said that about 20 to 25 years of age, the peak bone mass is achieved, and it remains at that level till 30 years of age. After the 30 years of age, it decreases and that reaches a maximum in the postmenopausal age. It has been noticed that the bone loss is less in the males as compared to the females. Now, what is peak bone mass? Peak bone mass is the greatest amount of bone an individual achieves. As the children grow, their bone mass increases until it reaches what is called peak bone mass. Peak bone mass is reached in late teens and early 20s. Children and adolescents who have peak bone mass adequate in their early adolescence, they are less prone to develop osteoporosis and then fragile fracture. Bone mass strength and achieved at the end of the growth period plays an essential role in prevention of the osteoporotic fracture in adulthood. It has been noticed that if there is increase in the 1 standard deviation of the bone mass, it will reduce the chance of 50% chance of bone fractures. The person who reaches the peak bone mass with low bone mineral density has less bone to lose, and those persons are more prone to develop osteoporosis and osteopenia, and their risk of fracture are increased in their life. It has been shown that achieving bone mass during adolescence could reduce or delay the consequences of osteoporosis and bone fracture by 13 years. So the adult life, they are safer in adult life. If they achieve the maximum bone mass, they are safer in their later age to develop osteoporosis and osteoporotic fracture. In this slide, we can see that there is bone reaches at peaks at 30s and then decreases. If the influencing factors like diet, exercise, and other factors are not controlled, the bone loss is quicker as compared to normal, which results into osteopenia and osteoporosis. Then what is peak bone mass and what is bone mineral density? The bone mass is the amount of bone mass as a total of protein and mineral, which is either in the whole of the skeleton or in a particular segment of the skeleton. Peak bone mass is the greatest amount of bone an individual can achieve. And bone mineral density is the measure of calcium and other minerals which are present in the body. That is, it is the test which is indirectly test the bone mass, and it helps to detect the risk of osteoporosis and fragile fracture in future. Now, this slide shows that we measure the bone marrow density by doing DEXA test. As here you can see, their specific T-score is given, and the T-score is given by comparing the normal population of having a graph of the normal population with healthy normal population with the person which we are examining the bone marrow density, and then this slide shows that the T-score specific T-score corresponds to the specific loss of the bone. It has been, you can see here that as this decreases, T-score decreases, it means it is, if it is decreasing from standard deviation is decreasing, then the bone loss, the percentage of bone loss is increasing. And already discussed by my other colleague that the bone, what is the normal bone marrow density, which is -1 to +1, T-score -1 to 2.5 is the osteopenia, and T-score less than 2.5 is the characterized, it causes osteoporosis. Now, how can we prevent osteoporosis and the fragile fracture? That is very simple things. If we do, we can prevent it. It is the achieving peak bone mass during adolescence, maintenance of the bone throughout life, and prevention of bone loss during aging. Now, health of the bone depends upon many factors. The hormones play a very important role in the healthy growth of the bone, as at the same time, nutrition and physical activity is very, very important in maintaining the good health of the life during whole of the life, starting from the childhood till the menopausal, post-menopausal age. Nutrition is very important, and if adequate balanced diet will help in the maintaining the bone mass as well as body in a healthy state. It has been observed in many studies that the postmenopausal patient or women who were using the Mediterranean diet were more or less prone to develop hip fracture. And the Mediterranean diet is very important because it is rich with proteins as well as the vitamin D and the calcium, magnesium, other minerals. So if our diet is composed of, say, seafood, fish, and the legumes and the vegetables, fruits, dairy products, these special type of diets will help in providing the adequate amount of protein in our diet. These will also provide the level in the recommended doses of recommended requirement of the calcium to our body, as well as vitamin D. Olive oil is also rich in the vitamin D, so combining the olive oil in the diet will increase the level of, will provide the adequate amount of vitamin D to our bones. So all these healthy diets will help in maintaining the health of the bone as well as health of the person. Recommended, it is shown here that the recommended daily requirement of calcium is high in the adolescent period because it's the peak time to gain the peak bone mass, and then the recommended doses or recommended calcium and vitamin D is also increased during the peri as well as post-menopausal patient. So second thing is the exercise. Exercise is critical for bone health throughout the life. Physical activity increases the bone mineral accumulation in the both children and adolescents. Strength or resistant activities are more strenuous exercises beneficial. Like resistant, mean just walking is not beneficial for the effective exercise for the maintenance of the bone health. resistant exercise and the strength activity is very, very important. Resisting exercise pushing or pulling against the resistance of the weight or the resistant our own body, like push-up, set-ups, step up. All these activities will increase the health of the bone, and these activities should be from childhood till menopause, post-menopausal age. There is no specific age for activities. We should make our routine to do these exercises, and it has been recommended that at least 2 hours to 30 minutes of exercise during a week, that more strenuous exercise or moderate intensity exercise, and a 2 full body muscle stretch exercise of 2 days a week is recommended by the physical guideline of American Society. So all these effects can help in the maintenance of the good health of the bone as well as our body. So the take-home message is the main way to prevent the having fracture is to maintain bone strength. Peak bone mass is attained by the age of 25 years. Peak bone mass is a key determinant of bone mass and fragility fracture later life. Age is independent factor affecting the bone strength, and optimization of calcium, vitamin D in our diet and weight-bearing exercises will help in decreasing the risk of osteoporosis in all the ages, resulting into prevention of fragile fracture in the left right. Thank you very much.
Thank you, Dr. Sadakat Javeen. I think you have covered everything nicely, from exercise to diet to attainment of the peak bone mass in utero origin and the early childhood origin and during pregnancy also. All these things, they matter in the primary prevention of osteoporosis also. That is when later on we have to give, of course, the when required, the reduce the bone loss, very important, and maintenance of, I think, balance, that we will discuss at the end of the our talks, because we want to keep up to the time, but we will definitely discuss for 10 minutes or so later on. So please, next speaker is our Dr. Brigadier Suraya Rahman. She will be just talking on sarcopenia, osteoporosis and vasculopathies.
Thank you, Dr. Maninder. Good evening, learning participants. A brief prologue before I start my designated crosstalk. I haven't got any slides because I was given less time and I was just told to mention the salient features. So our previous webinar in July was on physical and mental exhaustion, when I proposed to bring about the subject of sarcopenia, which I thought was relevant to the topic. Our dynamic convener, Dr. Maninder, proposed to hold a seminar on sarcopenia itself, but then she divided the topic and distributed the task wisely. So from the frequent messages, I thought today's seminar is basically on bone health, and I'm supposed to bring about osteosarcopenia briefly as a crosstalk. So I haven't made a slide.
Yes.
So crosstalk is a type of interference as defined in the literature. So I'll be happy to try to show how osteosarcopenia is characterized by concurrent occurrence of osteoporosis and sarcopenia as an emerging health challenge in an aging society, while adding its relation with vascular diseases in allotted time, hopefully. So in healthy aging depends on the ability to maintain the reserve capacity of multiple physiological systems. Of these, muscle and bone comprising the musculoskeletal system. The first speaker very nicely said about the musculoskeletal pain, Avir Sarkar. The musculoskeletal system are interlinked anatomically and functionally, not only enables human ambulation, but also serves as a major metabolic storage site, like calcium in the bone and glucose in muscles. However, as a person gets older, say he reaches sixth decade of life, there is a progressive decline in bone mineral density at the rate of -1 to 1.5% per year, muscle mass -1% per year, and strength -2.5 to 3% per year. This predisposes to the risk of osteoporosis and sarcopenia. 2 diseases with medical classification listed by the International Classification of Diseases. Owing to a highly interconnected nature of bone and muscle, a growing body of research suggests that osteosarcopenia intensifies the risk of fracture, falls, and hospitalization, and also further functional decline. So you see a bidirectional relationship exists between osteoporosis and sarcopenia, leading to the development of osteosarcopenia. Alarmingly, the aging population, especially in the affluent countries, are eating more and moving less in community dwelling as well as aged care facilities, leading to trends towards a musculoskeletal phenotypes with low bone and muscle mass and increased ectopic fat. This may manifest as osteosarcopenia, a term coined by Duke and colleagues first. It is important to note that it is a unique syndrome now, defined by the combination of low bone density, either osteopenia or osteoporosis, and muscle mass strength, and or functional capacity, which is sarcopenia, as a consequence of an increase in aging population from 841 million in 2013 to 2 billion by the year 2050, the prevalence of osteosarcopenia will invariably increase. I'll just mention a few words on pathophysiology, which is very important. In fact, many factors have been presented to explain this, from genetics, mechanical, dietary factors like protein and vitamin D, to hormonal factors may in part explain age-related association between muscle and bone loss, other localized and systemic factors are also involved. Indeed, the mesenchymal stem cells residing in the connective tissues such as muscles, bone, and fat are also implicated in osteosarcopenia. If you look at the epidemiology, prevalence increases with age and sex. It is greater in women. At the age of 60 to 64, more than 20%. More than 75 years of age, it is more than 48%. So it is the aging process and multimorbidity which is involved in the increase in prevalence. The risk factors, commonest is age and sex. BMI and physical activity are inversely related. Higher fat mass, malnourishment, poor balance, and functional performance are also very low in osteosarcopenic individuals. I'm not going to go into the clinical details like clinical outcome, clinical assessment, causes, the screening procedure, or the investigation and treatment, because that will be a long lecture. So I will just mention a very important screening or risk calculation tool for sarcopenia. It is called SARC-F, a 5-point sarcopenia questionnaire from the most recent international consensus guidelines. It is labeled as most accurate in detecting sarcopenia. And about the physical assessment, apart from the comprehensive routine geriatric assessment, 2 most widely used ones for the muscle strength test is the hand grip strength, sit to stand test, and for functional capacity, gait speed test. These are the 2 important tests which is most widely used. The investigations are to be planned according to the clinical findings or the clinical causes that we see. Treatment, the randomized control trials have demonstrated the efficacy of resistance exercises and balance exercises at least 2 to 3 times per week, which will improve the muscle mass, bone mass, strength, and balance, lower the risk of falls and lower the risk of fractures. But we have to supplement with vitamin D, 100 to 1000 international unit per day, protein more than 1.2 grams per kg per day, calcium 1300 to 1500 grams per day, creatine 3 to 5 grams per day. So all this supplementation along with the resistance and balance exercises are the remedies. Pharmacotherapy, there are no approved pharmacotherapy against sarcopenia as yet, which is approved, in contrast to osteoporosis, for which they are widely available in the form of anti-resorptive, anti-sclerotic, anabolic, hormone replacement, and SARMs. Indications, availability, cost, and approval will vary globally. But here I just want to mention about one agent which has shown promising effects on muscle and bone alike, which is denosumab, a rank ligand inhibitor. It improves both muscle mass and bone mass along with the strength, and also improves balance. Association with coronary artery disease. Like osteosarcopenia, coronary artery disease is another public health threat, a leading cause of morbidity and mortality worldwide. Detection of subclinical coronary artery disease is of paramount importance to prevent overt cardiovascular diseases. Coronary artery calcification scoring using computerized tomography is a representative risk marker for coronary atherosclerosis, which reflect the total coronary atherosclerotic burden. Furthermore, coronary artery calcification can predict cardiovascular events, including mortality, and outperforms other risk factors. Studies have revealed that sarcopenia or osteoporosis alone is closely related to cardiovascular diseases and their risk factors, that is hypertension and metabolic syndrome. Thus, osteoporosis is very strongly linked to cardiovascular risk. I just want to conclude by saying some important points, which is osteosarcopenia is a newly established syndrome. Its biological etiology and impact on clinical outcomes on older adults have only just begun to emerge. It is at the forefront of geriatric medicine and is going to be routine healthcare issue in future geriatric practice. Identifying biomarkers to improve diagnosis, risk strategies, and targeted treatment should be the goal of future research activities to combat growing burden of osteosarcopenia. Thank you, learned participants. That's all I had to say.
Dr. Suraya Rahman, that was wonderful crosstalk. And जैसे we say in Hindi, gagar mein sagar, that means in a small vessel, you can put in the whole ocean. So that is what you have done. And of course, we will be doing more webinars on sarcopenia, because that is the topic of the future and need of all of us also in the menopausal women. And there is a definite relationship now between sarcopenia and osteoporosis. So we had to bring this topic in. And thank you for volunteering. And next time you will arrange complete webinar on sarcopenia, because I know it has many tentacles like octopus. We have to discuss a lots of things. Thank you very much. We'll be doing discussions later on. Next speaker is our Dr. Lakshman Viraj from Nepal. We are honored to have you here, sir. And after that, we'll have Dr. Jignesh Shah from India talking on very, very important issues we are sometimes ignoring in our talks. So medical treatment of postmenopausal osteoporosis, because we as gynecologists are sometimes not aware of these, when to prescribe, which conditions to prescribe. Let's see what the Dr. Lakshman Rijal will be enlightening us on this topic, medical treatment of postmenopausal osteoporosis. Sir, to you.
Good evening, everybody. Now onwards, my job is to make it easy so that you can prescribe treatment for postmenopausal osteoporosis. This is a very common condition. We encounter cases every day in our OPD, and there are so many societies. They roll their dice by the way they want to. They recommend their guidelines. But in case of postmenopausal osteoporosis, most of the societies have the similar guidelines and the consensus is very conclusive. So the job is very easy. The mainstay of treatment of postmenopausal osteoporosis can be divided into lifestyle measures, supplements, and pharmacologic therapy. The lifestyle measures has almost been covered by the previous speakers. The supplements, we all know about calcium and vitamin D, and pharmacological therapy, I'm going to put some points on it. So this has already been highlighted. This is the FRAX scoring system. The role of it is to decide when to treat, whom to treat. So the FRAX scoring system and the DEXA scan gives us the group, or we can divide it into group, the low risk group, the moderate risk group, or the high risk group. Amongst all the three groups, moderate and high risk groups, they should be treated with the. So these are the drugs available for postmenopausal osteoporosis or the osteoporosis treatment as such. I have the broad two groups. One is the anabolic groups that contains the teriparatide and abaloparatide. The second group is the anti-resorptive groups, the bisphosphonates, the denosumab, they come under this group. So by and large, bisphosphonates, they are the drug of choice for postmenopausal osteoporosis. Bisphosphonates can be started orally or intravenous. The oral dose is per weekly dose or monthly dose, whereas the intravenous dose is a dose to be given every year, a single dose every year. So when we start the treatment, after 3 years of IV therapy, we reassess the fracture risk again. In case of oral group, we reassess the fracture risk group at the end of 5 years of therapy. If the reassessment gives us improvement and moderate is converted to low or high into moderate risk, then we can give a bisphosphonate holiday for at least 3 to 5 years. That is discontinuing the bisphosphonate. For high risk group, we would. For high risk group, we treat 3 more years with bisphosphonate and again reassess. If at the end of 6 years, if we are not happy with the response, then we switch over to the another molecule. Bisphosphonates have said to have some side effects like osteonecrosis of jaw, but the risk is very low, 0.021% with 4 years of treatment. If we encounter the case of osteonecrosis of jaw, it settles with the discontinuation of therapy in many of the cases. The another difficult side effect is atypical femur fracture, but the risk is still very low, 3 cases per 1 lakh population after 2 years of therapy, or 20 cases per 1 lakh of population on treatment after 5 years of usage. Similarly, 50 per 1 lakh population treated with bisphosphonate at the end of 8 years. So when we compare risk versus benefit, it's always a benefit than to think about the atypical femoral fracture with the therapy. This is one of the cases of the atypical femoral fracture. Any patient on bisphosphonate, if complains the thigh pain, they have to be screened with the X-ray. Even with simple analgesics, if they are not responding, they have to be sent for bone scan or X-ray, followed by bone scan or MRI to diagnose. In most of the cases, X-ray is sufficient. Now coming to denosumab, it's an alternative therapy that works in the rankle ligand, and it's alternative for the treatment of high-risk group. The beauty of denosumab is there is no drug holiday, and the treatment can be started and continued for 10 years. We have safe data up to 10 years so far. And we do not discontinue denosumab without other therapies in continuation. That means at the end of 10 years, if you have to discontinue denosumab, we add subsequent bisphosphonates. BMD returns to baseline after 24 months or 2 years after discontinuation of denosumab. So it has to be continuous with other therapies. So we have 10 years data available. The dose is 6 monthly plus minus 1 month gap. If you keep a gap more than 1 month, the BMD falls very sharply. So the gap has to be maintained within a month of last dose. Side effects are also similar with bisphosphonate, but they have some unusual side effects like hypocalcemia, but they remain unnoticed in most of the cases. They are not threatful. Teriparatide, we call it a wonder molecule for treating osteoporosis, and the recommended dose is subcutaneous every day for 2 years in high-risk patient with fracture or without fractures. This causes sometimes increased serum calcium level that remains unnoticed, and it's very transient, lasts for 2 to 3 hours after injection. There is no risk of osteosarcoma in humans, but the trials with the rats, they have seen some cases. So far in human, it has not been reported. After 2 years of therapy, 2 years is the whole life therapy. You don't need to add more than 2 years. After 2 years, you can add the anti-resorptive therapy with bisphosphonates. So monitoring the therapy is very easy. At the end of 2 years of initiation of therapy, or sometimes people do it after 1 year also, we repeat the DEXA, and we can assess with bone turnover markers. We can assess 2 types of bone turnover markers. One is the anabolic markers, the other is the catabolic markers. So catabolic markers like CTX and NTX or the urine pyridinoloins can be assessed, or the anabolic markers like PINP, bone ALP, or PICP can be assessed. These markers has to be sent before initiation of therapy, and at the end of 3 months of therapy or 6 months of therapy, you can repeat the test. This will guide you whether your therapy is responsive or not. And we always call a good response if the BMD is stable or it is increasing. Even the stable BMD is said to be the response of therapy. So coming to the conclusion with the cases, the choice of therapy, I call it osteoporotic or postmenopausal osteoporotic with prevalent vertebral fracture. The drug of choice is teriparatide, that is parathormone hormone analog. It is given subcutaneous for 2 years and should be followed by other anti-resorptives. This is the first line of treatment. Zoledronic acid, denosumab, and alendronate follows teriparatide in sequence. If teriparatide is not available or if it is not affordable, then we can go for zoledronic acid. But the drug of choice for vertebral fractures, postmenopausal osteoporosis, teriparatide is the drug of choice. Postmenopausal osteoporosis with prevalent hip fracture, there is a great role of zoledronic acid intravenous, and in a regular practice, what we do is we fix the hip. Before discharge, we give an IV zoledronic acid so that the whole year is covered for the treatment or the therapy. If zoledronic acid is not of use or cannot be used, then we can straightway go for denosumab subcutaneous. That's a 6 monthly dose. But the role of teriparatide in case of hip fracture is less discussed, or it has less role than what zoledronic acid has. So high risk without fracture, we can start with zoledronate IV. That's a yearly therapy again, or denosumab 6 monthly therapy, subcutaneous, but 6 monthly denosumab, 6 monthly subcutaneous therapy. But in case of low to moderate risk without fracture, we can get away with alendronate weekly, that is a oral tablet, or zoledronate IV, a year injection per year. So these are the choice of therapy in different groups, but by and large, bisphosphonate is the drug of choice to start with. So role of HRT is very much well discussed by the previous speakers, or the raloxifene or tibolin. They have a selected candidate, they have selective candidates for the initiation of HRT, and it really works like a magic. Early menopause with symptoms within 10 years of menopause or less than 60 years of age are the ideal candidates. Matter of concern is the risk of breast cancer and thromboembolic phenomenon should be searched for in every patient before starting. So concluding, I would like to say menopause is just a physiology. If you can maintain your bone health, you can do whatever you like. This is a lady from Japan, 73 years old, and she climbed Mount Everest, and she has a Guinness Book of World Record in her name, saying that she's the eldest lady at the top of the Everest. I would like to thank you for your time. Thank you all.
Thank you, Dr. Lakshman Ridal. I think that was a wonderful, wonderful talk. You have cleared many doubts. Most of them will be now knowing how to start the treatment. The only thing which I wanted to know, what is the cost of this thing, teriparatide in your country?
Teriparatide is something around, it comes around 6,000 to 8,000 a month, ma'am.
Okay.
So for a whole month, you can.
And denosumab?
Denosumab is 20,000 for 6 months. It's even cheaper. It's even cheaper.
20,000. Okay. This is the cost, because then if we have to look into a common rural women coming to us, they also come to us. People will be thinking that they don't have osteoporosis now because of the changed lifestyle. The rural women are also coming to us with osteoporosis, and most so, as Dr. Suraya Rahman said about the sarcopenia. So what I used to do mostly in these patients was to do the grip test, wrist grip test. I'll do the hand holding with them and compare them with my strength. Why I used to compare with my strength was because I was doing my gym exercises regularly. So I could watch for my strength to some extent. So now we have the dynamometers available where you can say it's 10 to 16 kg per with the women should be able to do. That is the important part. Now we have to come to the last topic, and then we will be taking the discussions. Dr. Lakshman, be there. We might have some questions later on for you. So please don't leave. Dr. Jignesh Shah is our next speaker, and he was the past president of Indian Menopause Society also. And he's a very, very, active member of the Menopause Society, who is now working on the idea of starting the menopause clinic, because that is the way forward now, perhaps to disseminate the knowledge, and some practice increase will be there, because that is the way we'll be creating. Once we open up 10, 14, 20 clinics in a city, the people will definitely know about the menopause also. And that's a wonderful idea if we can start like this. And he'll be talking on very important topic of osteoporosis alternative therapies, because we just start sometimes with HRT and we don't advocate that alternative therapies. And to some extent, he'll be talking about exercise.
Thank you, Maninder, for this invite. Talk is role of alternative therapies and exercise. I think except alternative therapies, everything is covered. Most of the part of the exercise is also covered. So first we will start with the exercise. We all know that because of the estrogen deficiency, it speeds bone loss and increases the risk of osteoporosis, and it is not reversible. But with the help of medicines, along with good nutritious diet and weight-bearing exercises, we can help prevent further bone loss and rebuild bones. And our main aim in the treatment is to prevent the fall and the fracture, to reduce the morbidity as well as mortality related to the fractures. Now, first, we will start with the exercises. It was already clear that walking, swimming, and cycling, they have very little or no effect on preventing age-related bone loss. So that should, there is a myth in the elderly woman that I am going for walking for half an hour and no osteoporosis will occur, then we have to clear it. Then second is progressive resistance training exercise. These PRT exercises are recommended as an effective strategy to increase or maintain BMD in postmenopausal women, because what happens, first it will have a strain, then there will be a direct pulling action of the muscles, which will result in increased effect of gravity acting on bone and further bone loss or osteoporosis will be prevented, and some amount of osteoporosis, calcium deposition will be occurred. Next is high velocity power training and balance exercises. High velocity power training exercise, they may induce high strain rates on bone, and balance exercise, it can reduce the risk of falls and fractures. So both are very important. Then weight bearing exercises, they are the short bouts of weight bearing impact exercise, and that includes 3 to 5 sets of 10 to 20 jumps with the weight or without the weight, with moderate to high magnitude of loads that must be more than 2 to 3 times of body weight, and in multi-directional movement patterns, they will promote or maintain the bone health. It will prevent further bone loss in elderly patients. So nowadays, the recommendation is multimodal exercise training that includes 2 or more activity modes, such as weight-bearing activities along with pressure raising exercises and power training and balance and mobility training. And they are currently recommended. So we have to balance it in such a way that 2 days a week we go for the PRT and 2 days we are going for the balancing activities. And if we are going for yoga with these exercises, then it gives the excellent results. Orthosis, again, it is a device that supports or immobilize the part, especially spines or hip joint or knee joint, and they can help in prevention of fractures. Then is, why this is not seen here? Yeah, Tai Chu Chuan. This is a Chinese exercise. It is a mind-body exercise which is a low-impact weight-bearing exercise that requires no jumping and involves well-coordinated sequence of movements in the trunk and extremities, neuromuscular coordination, and low-velocity muscle contraction. So this includes the contraction exercises, then meditation, along with the breathing exercises. And then we will talk about the alternative therapies. They are the calcium, vitamin D, calcitonin, fluoride, omega-3 fatty acids, and vitamin K. These are the dietary supplements, along with phytoestrogens, herbs, yoga, acupuncture, and chiropractic care as alternative medicines. So we have many options. Calcium and vitamin D already has been talked in details. We know the importance of it. Then calcitonin already talked. Fluoride, this was not covered in the talk, but it has direct anabolic effect on the osteoblast, and it is the only osteoblastic as well as anti-disruptive drug. Omega-3 fatty acids, they increases the bone formation and decreases the bone resorption, and vitamin K promotes bone mineralization via osteocalcin. Now, let us talk about alternative medicines. First is phytoestrogens. They are the plant estrogens. They are estrogenic as well as anti-estrogenic. They act like some. In some tissues, they have estrogenic effect. In some tissues, they have anti-estrogenic effect. They are weak estrogens, and they are the isoflavones, lignans, stilbene, and comestan. These are the various diets which are rich in the phytoestrogens or plant estrogens. They are flax seeds, sesame seeds, soybeans, cruciferous vegetables like broccoli, garlic, ginseng, wheat bran, oats, peanuts, almonds, this pomegranate, dates, and licorice. So these are the food which are rich in the phytoestrogens. The other herbs are red sage, that is also known as danshan. It is a Chinese herbal medicine, and it is associated with improvements in osteoporosis in many of the studies, but these studies are very small size, so we cannot be dependent on it, but in China it is very popular. Second is red clover. This is a perennial herb, and it has been used as a complementary treatment for menopausal symptoms, but its role in preventing osteoporosis is not proved. Third is thyme. It is a herb which is just like ajwain, and it is a mint type of herb. And researchers found that regular consumption of thyme improved bone mineral density better than a calcium and vitamin D3 supplement. Then comes the role of yoga. Yoga is again an Indian traditional way of good healthy living. It is a mind-body practice which combines physical postures, breath work, and meditations. It benefits everyone in any condition, starting from the adolescence to all ages. It can be done, and it will help in all the diseases, but it will allow us for better posture, improved balance and flexibility, enhanced coordination, greater range of motion, increase muscle strength, and increase bone density. So yoga is a very good exercise, and especially the asanas like Vrukshasana, then Padhastasana, Trikonasana, Setubandhasana, and Salpasana, they are very good for bone strength. One more Chinese way of practice of acupuncture as well as acupressure, they are known to be effective in improving osteoporosis. There are many studies which suggest that acupuncture is effective in improving osteoporosis. And chiropractic care is very popular in America, Canada, and Australia. In India, we are calling it Hadvaid. They don't directly treat osteoporosis, but they can help manage some of the symptoms associated with it. It will alleviate pain and discomfort, but it has no role in improvement in osteoporosis. So to summarize, it is always better, safer, and cheaper to prevent the development of osteoporosis. And if we start early, we can prevent osteoporosis. So as a gynecologist, we should start telling the woman from their adolescent age group to start exercise, to have good nutritious diet to prevent the osteoporosis. And it is already said that it is a fetal origin of adult disease, where in healthy mother, the healthy skeleton may be observed in the fetus. And exercise and alternative therapy can play a synergistic as well as complementary role after development of osteoporosis. So thank you. I was the last, so I have hurried it up, and thanks.
Thank you, Dr. Jignesh. You have given a wonderful talk, and you have covered all the points, all the alternative drug therapies, and exercise also to a very beautiful way. And especially you have explained all the exercises in yoga, and you covered that yoga in the cradle sort of thing, where a swing yoga they are doing. So that also helps. Especially I have seen in USA that they are doing those exercises in cancer survivors also, because when they are giving them for the prevention of breast cancer especially, tamoxifen they are giving. So naturally, more chances of getting their osteoporosis are there. So they are given along with zoledronic acid, which they regularly give them to every year, that advise them to go for these exercises, especially weight bearing, resistance, and these sort of yoga exercises also, which can increase your bone mass density. Especially just for the adolescents, I wanted to add one point for all the speakers and all the delegates who are here, that is the time period when our adolescents, they are back into the studies at a very speed, because they have to clear their NEET examination, they have to clear their entrance examination, they have to bring the good scores. And where is the time for all these physical activities, which I advise, at least in schools, 1 hour should be given for the physical activity in the open grounds and high impact aerobics. Like that means lawn tennis, basketball, throw ball, all these exercises where they have to do high impact exercises, they should be definitely a must for all the adolescents in all the countries. Like even the UK, Dr. Mary said that adolescents are not doing much of physical activity. Secondly, what I advise to the girls, where they're from the especially very low socioeconomic strata, that they can do skipping. We used to do lots of skipping. And they say if we do 50 to 100 skipping per day, which is very easy to do, then that will be very good for attaining their peak bone mass and then maintaining also till the time they go into the perimenopause or post-menopause, when we don't advise high impact aerobics to these women. Now it's over to you, Dr. Sanath, to take summarize and take any question answers if they are there.
Okay. Thank you very much, Dr. Maninder. First of all, I'd like to extend my heartfelt thanks to you and your entire team to arrange such a wonderful webinar today. Thank you very much. Well, already we're at the end of the discussion from the two brilliant lectures, from the comment from the esteemed panelists, the comment from our honorable chairpersons and the moderator. We came to know a lot about osteoporosis and sarcopenia. Well, I'll go to the question, but one thing I want to mention here, that musculoskeletal joint pain and osteoporosis go hand in hand. So, yeah, we can't separate those from osteoporosis as well as sarcopenia. Osteoporosis, we have had a wonderful lecture from Marian that we know it is a brittle bone, porous bone, and is associated with the fracture and gives a lot of sufferings, mental, physical, and social, as well as the whole economic burden. So this is very important. And I would tell later a few words.
There are some questions from the
I am going to the question. Dr. Asif, he has asked the question, what is the role of environmental pollution and middle life musculoskeletal pain? And that will go to Dr. Avir Sarkar.
Environmental pollution as such has been seen to be associated with depletion of musculoskeletal pain problems. But the main association, I think, is that the various pollutants are thereby leading to pollutants in the form of water pollution and the rest of the pollutions are leading to more amount of substances which will inhibit the absorption of calcium and vitamin D3. And when there is depleted absorption, then as such the the bone strength and muscle strength goes on decreasing. And moreover, the lifestyle of the women are also changed in polluted areas. So these all things might be the causation to.
Thank you. Thank you, Dr.
Avir, can it be pro-inflammatory states because of these pollutants?
Yes.
So
exactly.
Low estrogenic state itself is now being recognized as an inflammatory state, and various cytokines are being involved. So I think that can be one of the main reasons for these causing the muscular pain. And I've seen I have seen the difference in USA and in India, because I was in USA just 1 month back for 1 month there. And I was feeling so good there, and I could walk and do the exercises, which I'm not able to do here now at all because of the heat and the
humidity. And
no, it's not that humidity. It's the main pollution of the air, which I'm feeling now the difference. So that is what is important. Yeah.
Thank you. Thank you, Avi. Yeah, thank you, Avi Sarkar. But I want to add here a little bit, that is the fizzy drinks, which is containing lots of soda, is another toxic, born toxic agent. Okay, fine. Now our next question is, what is the role of parathyroid hormone in postmenopausal Indian patient with diabetes? And is this supposed to be first line of treatment instead of bisphosphonate? It will go to
Dr. Lakshman.
Yes.
This question is for you. What is the role of parathyroid hormone in therapy in postmenopausal Indian patient with diabetes?
With diabetes.
And is this supposed to be the first line of treatment instead of bisphosphonates for a 65 to 70 years old lady? That's a very important question.
Yeah.
Even I wanted to ask this.
It is still the first line of treatment in case of diabetes and postmenopausal osteoporosis. If she has a fracture of the vertebra, then we can switch over to the teriparatide. Otherwise, teriparatide is not the drug of choice in such case. And diabetes is not the contraindication for teriparatide. You can very safely go with teriparatide. Teriparatide, in a Japanese study, they have found that even in the end-stage renal disease,
it can be given. Yes. Thank you, Dr. Lakshman, but it is very expensive. In that case, I think I know that how much expensive this is. So bisphosphonate can be used in this case?
Yes, bisphosphonate is the drug of choice in this case.
Right. Okay, thank you. Thank you very much.
Dr. Jinnat, once the fracture occurs, the surgical treatments are much more costlier. That devastates the life of a woman. So please, we have to counsel them. That might be costlier, because I have seen now the patients are ready to spend. When they have end-stage cancer now, they will sell their homes to get the treatment when it is not feasible at all.
Exactly.
Right. When the fracture is there, it's better to prevent it.
Right. Life is more important than cost. So next question. Very nice presentation. From Kasun Bandrara. She asked that, Professor Mary, do you prescribe HRT to low and intermediate risk group of opportunistics measure? Then Marianne has left there, but we can answer yes. It has been evidence-based that MHT has tremendous role in prevention of the osteoporosis. Though osteoporosis cannot be prevented at all, but it has seen that 2 years of even use of menopause hormone therapy increases the bone mass density. So we can use that. Okay, I don't think any questions are left. There are no more questions, so we can conclude very short, because it is already 10:30, 10:40. So yeah, so in Bangladesh it is already 10. Okay, fine. So what I'm trying to conclude this session with saying that yes, osteoporosis, it is a silent killer, and it is very, very bad. Even from Piyusha, we have seen how much South Asian women are suffering from that. So, and we all know that fractures is the most debilitating part of osteoporosis. One fracture is happening in 3 seconds. So we have to be aware. We have to build awareness, advocacy among the society. It should be started from the childhood. That is already, we have shown the peak bone mass density has been achieved by 25 years of age, which is said by Professor Sadaka very nicely. And then, of course, the nutrition was spoken by our one panelist very nicely, that we have to increase the awareness about the protein intake, calcium, vitamin D, exercise, avoiding the smoking, avoiding excess of alcohol, avoiding the bone toxic agents. This is very important. And of course, in later age, when there is a chances of osteoporosis and osteopenia, who are already have that, we have to adopt the strategy for fall prevention. Lastly, what is important to say that yes, whenever women are coming, it is silent. Unless it is a fracture, we don't know whether she's suffering from osteoporosis or not. That is why Avir Sarkar told that early screening, that one of the panelists said very nicely, either FRAX or using the diagnosis or DEXA, whatever it is important, we have to do the early screening, early diagnosis, early intervention. No doubt that is the most important. And of course, which are being modifiable, that is the lifestyle modifications is important, which are the bedrock to prevent the osteoporosis related fracture and thereby the death and morbidities. And finally, Dr. Laxman said anabolic tablet, non-pharmacological treatment like anti-absorptive as well as anabolic. So probably Dr. Maninder already said cost is nothing, but still I have to say in perspective of our status, bisphosphonate could be the first choice of drug. MHT has tremendous role, no doubt. If it is indicated, women should be advised that yes, MHT has a beneficial role in prevention of the osteoporosis and the fracture-related morbidities. And lastly, I have to say that yes, lifestyle modification, pharmacotherapy, and exercise, which was mentioned by Jignesh very nicely. I want to stop with saying that it was well informative, eloquent, and extraordinary webinar today we have enjoyed. Thank you very much.
Thank you, Dr. Sanath. Now is my time to say thank you to all the faculty, whole of the faculty and the delegates which have been there, starting from Dr. Rohana, who could not make it, but I know we must be missing it. Then Dr. Mary Lumsden, Dr. Yashodhara, Pradeed, Dr. Sanath, and then my panelists, Dr. Lakshman, Dr. Jignesh, Dr. Sadakat, and Dr. Dasan from Akmeemana, and
anesthesia.
Yeah, everybody, and last but not the least, Jagsonpal, because without them we won't be able to do the seminars. And I tell you, their products are really good because they may not be available in your country, but in Indian society, they have helped us do research also. So LycoRed molecules was under research of Indian Menopause Society, and we found it very effective even in osteoporosis. And then for magnesium, their Krampoff is very, very good. Even personally, I have tried. So thank you very much and good night, everybody.
Thank you.
Thank you. Bye-bye.
And we'll meet again now with either the bladder symptoms. So please be prepared for that.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Very beginning to end.
Thank you. Allah Hafiz.
Thank you.